Hello, everyone. I'm Dr. Laura Markley from Akron Children's Hospital in Akron, Ohio, and today my update is entitled You Did What? Understanding Adolescent Behaviors and Risk in a Developmental Framework. I have nothing to disclose. And our objectives today will be to describe key developmental and neurobiological factors that contribute to the risk-taking behaviors in adolescence, including the interplay between the emotional regulation centers of the brain and executive functioning. Identifying current trends in adolescent substance use, suicide, and violence exposure, and recognizing how these behaviors are influenced by social, environmental, and policy level factors, and to evaluate the impact of social media and digital environments on adolescent mental health risk. So, let's focus on adolescents. Well, adolescents represent the highest risk group for the onset of new mental illness. This is associated with the developmental period marked both by heightened vulnerability due to rapid neurodevelopment and critical opportunity based in shifting identity, increasing autonomy, and changing roles. National data have shown that there are rising concerns around mental health, exposure to violence, and digital risk, especially in those who were assigned females at birth and LGBTQ+ youth. Evolving social media environments and policy changes, such as cannabis legalization, online safety laws, are actively reshaping risk trajectories. So let's talk a little bit about adolescent neurobiology and vulnerability. A conversation that I find myself having on a pretty much daily basis with parents and with young people is that even though adolescence is a time period marked by significant development of the brain, not all of the brain develops at the same rate or even at the same time. So I end up explaining that the back of the brain and the brain's emotional and reward systems develops far before the front of the brain, the prefrontal cortex, and let's say the common sense systems. So your gas pedal is fully developed and ready to go far before your brake pedal is fully functional. And that is something that creates an issue in their ability to show good judgment and self-control. So what does that mean for adolescents? Well, it means that they're going to have a heightened drive for novelty, pleasure, risk-taking, and that's going to be combined with an underdeveloped common sense filter. So I usually explain to parents that on a good day, they can tap the brakes about 50% of the time. If you add in other issues like ADHD, substance use, things like that, it becomes even further removed. So when these experiences take place during adolescence, either very emotionally or chemically charged memories can imprint early and prime vulnerability to substance use disorders or other high-risk behaviors. So what we end up with is a situation where a fully developed back of the brain is getting reinforced and strengthened through highly emotionally charged experiences, through substance use. Those reward circuits are getting stronger and stronger at the same time that the frontal lobe that is trying to develop is having a stunted development. That inequality is not a fair fight. So I try to conceptualize what's happening in the adolescent's brain with them in talking about how can we help your brain put up a fair fight to help you make better choices. So what we just discussed leads to a greater understanding of what is on this slide, which is basically a demonstration that the earlier a substance is first used, the more likely the individual is to have a substance use disorder later on in life. In this particular study, the age at first drink was inversely related to the risk of developing an alcohol use disorder. If someone had their first drink at age 13 or prior, they had a 47% risk of having an alcohol use disorder develop during their lifetime. However, those who were able to delay alcohol use until age 21 or older had only a 10% risk. The same was true with marijuana. Almost 20% who used at age 13 or younger went on to develop a marijuana use disorder, whereas only 4 to 5% who used at age 21 or over ended up developing the same issue. So what this tells us is that the brain needs time to develop. The frontal lobe needs time to marinate to protect us from developing these disorders. So delaying use, even by a few years, can greatly reduce the chance that someone will develop a substance use disorder. On the flip side of that, why does it seem like society is making our job so hard, convincing kids that that's the case? Well, because it's because aiming at young people is profitable. In general, most substances of abuse follow kind of the 20%, 20-80 rule, which is that about 20% of your population needs to use at least 70 to 80% of your product. Basically, you need a stable base. So how do you ensure that 20% of your use population is going to be in a position to consume more than usual amounts of substance to keep you in business? You start them young. You basically breed a population of people who will consume your product throughout their lifetime. So I like to conceptualize adolescence as toddler 2.0. And while I'm talking, I'm going to play this very cute video of my nephew taking some of his first steps. And it's really because adolescents are gaining new abilities, they're increasing their mobility and their independence. If they're not driving, their friends are driving. They can get rides places. They can say, well, you don't have to take me. That's not a reason I can't go. I can find a way to go. They have more social opportunities. They're very emotionally easily overwhelmed. If you think about that analogy again, where that emotional part of the brain is developed, but the ability to regulate that emotional part of the brain is not, it makes sense. Parents are key in modeling stress responses. Teens are very curious about their expanded world access. They have an impaired ability to determine risk, and they need close supervision and support and limit setting, but they don't necessarily like it. They can also be very prone to tantrums if they don't get their way. So that's, does that sound like any other group? And, of course, my adolescents don't like when I point out that there are similarities, but there are definitely similarities with these two stages of life. So now I'm going to read you some quotes from some patients that I evaluated while I was on the consult service. Everything is de-identified. First one says, I don't know what I was thinking. I was upset, and the next thing I knew, I was holding the bottle and taking them. I don't know what I was thinking. I don't know if I was trying to kill myself. I don't think I would do that. The next was, I was so upset I couldn't calm down. So I tried to take a shower because sometimes that helps. I even cut a couple times even though I hadn't in months. Then I got out and I saw the medicine cabinet and it was like, I'm just going to do this. And I took them. I couldn't find the bullets. I had the gun, but it was empty. So I went looking in their room and I found where they hid the pills. So I was like, okay, new plan. And that's what I did. Is there an opportunity for us to make a difference in the healthcare realm? Absolutely. Most young people that die by suicide visit a healthcare provider in the months or weeks prior to their death. 80% of adolescents visited a healthcare provider within the year prior to their death by suicide. Half of them visited an emergency department within the year before their death. 38% of adolescents had contact with the healthcare system within the 4 weeks before their death. And 34% of people aged 15 and over had contact with a healthcare provider in the week before their death. The important thing to realize here is that not all of these contacts were for mental health reasons. Many of them had physical complaints. So there is a strong argument for universal screening of suicide risk amongst those who are presenting to our medical institutions for care. It's widely recognized that the pandemic caused a significant amount of mental stress amongst multiple age groups. However, there was a disturbing trend in children in the 20 years prior to the pandemic that's demonstrated on this slide. This slide shows that misuse or abuse ingestions between 2000 and 2020 remained relatively constant, but there was a dramatic increase in suicidal ingestions in all age groups over 9 years of age. And the greatest increase was in the age group between 10 to 12 years. I bring this up because many times people identify adolescence as the time period that happens during the teenage years. We know that it is a spectrum that can start prior to the teenage years and extends into the 20s. So really not limiting our concern and our screening to those that are in a narrow age range is important. We really need to expand our consideration of risks to a much broader population of children than we generally are. So now I'm going to move on to talking about some of the things that can widen the gap between the strength of the emotional brain and the weakness of the frontal lobes during adolescence. And one of those is marijuana. I put up this slide and the next to demonstrate that in 2024, if you looked at the population of teenagers reporting a major depressive episode versus those not having a major depressive episode, the group utilizing marijuana, which is the group in blue, is at much higher risk for experiencing a major depressive episode in the last year. This slide looks at past year or past month substance use amongst adolescents aged 12 to 17 by severity of anxiety symptoms in the past 2 weeks. So those using cannabis or marijuana or THC products reported much worse moderate to severe anxiety symptoms. One can extrapolate that if marijuana was effective at treating or ameliorating depressive or anxiety symptoms, the symptoms should be less in those who are actively using. However, in studies and in reality, we are aware that marijuana, especially in youth, worsens both depressive and anxiety symptoms. This slide demonstrates that results from 3 studies that measured the association of cannabis use during adolescence with subsequent suicidal ideation in adolescence and in young adulthood were pooled with a resultant odds ratio of 1.5. And those looking for the number of suicide attempt outcomes within adolescence or during young adulthood, the results were pooled with a resultant odds ratio of 3.46. I've additionally added another study at the bottom from 2023 that demonstrated that adolescents with cannabis use disorder had roughly 40% higher odds of a suicide attempt or self-harm combined with depression. If you were diagnosed with both, the odds of those rose ninefold. So let's talk a little bit about how marijuana and THC legalization is affecting adolescent suicide rates. A recent study published in the Journal of the American Academy of Child and Adolescent Psychiatry looked at suicide rates in youth who were 12 to 15 years old and compared rates in states where there was no legalization, states where there was legalized medical marijuana, in quotations, and states with legalized recreational marijuana using data from the National Vital Statistics System. The unadjusted annual suicide rate per 100,000 was 9.76 for no legalization, 12.77 for medical marijuana, and 16.68 for states with legalized recreational marijuana. Among female identifying youth, compared to states with no legalization, there was a 10% increased suicide rate, so death by suicide rate, in states with legalized medical marijuana, and a 16% increase in death by suicide in states with legalized recreational marijuana. Additionally, across female and male identifying youth from 14 to 16 years old, youth in recreational marijuana states were at 9 and 14% higher risk for suicide, in contrast to youth in states with no legalization or medical marijuana, respectively. And the authors noted that these data are consistent with what we know about cannabis use prior to 16 years of age having distinct impact on adolescent neurodevelopment and cognitive functioning. Another factor that can worsen the mismatch in neurobiological development in adolescence is violence exposure and trauma. Daily exposure to violence increases emotional distress, increases risk behaviors, and can worsen conduct problems. Chronic exposure disrupts neurodevelopment in ways that are going to seem very similar. Trauma and violence exposure dysregulates the stress systems and reinforces stress and emotional circuits so that they are hyperreactive, and this leads to a heightened emotional reactivity. At the same time that quote unquote back of the brain is overactive, the front of the brain, or the prefrontal cortex, has reduced activity and reduced development. These neurobiological changes contribute to a greater risk for PTSD, self-harm, and substance use. Unfortunately, violence exposure and trauma is still a very real problem for many adolescents. 1 in 5 female identifying students reported experiencing sexual violence and persistent hopelessness. 14% of all students reported bullying at school in the past year, which was an increase from 2021, and it was unequally represented by LGBTQ+ youth. LGBTQ+ students are significantly more likely to experience bullying, sexual violence and dating abuse, homelessness and housing instability, and suicidal ideation and attempts. Transgender and questioning youth, which were newly tracked in the 2023 YRBS, reported the highest risk profiles of any group. How do we put this all together to help parents and families better address what's going on neurobiologically to prevent risk in the adolescent time period? Talking points that I use with adolescent parents are that overdoses, as well as other suicide attempts or self-harm, are frequently impulsive actions following an acute stressor. And the lack of brain development at that age makes every single teenager vulnerable. Again, I say that the gas pedal, or the emotions, are always engaged and fully developed and only getting stronger. And the brake pedal, or the prefrontal cortex, is not fully developed and it's variably engaged. So putting those things together means that no matter how logical someone is at their emotional baseline, when they get pushed to a certain point, everyone is at risk for making an impulsive choice. THC use and violence and trauma exposure all worsen emotional dysregulation, slow or stop frontal lobe development, and increase suicide risk. When I'm talking to families about SSRIs, I point out that they have never been associated with death by suicide, only with a potential increase in suicidal thinking, whereas the THC that their child is lobbying to take for their depression is associated with a greater risk of death by suicide. The best deterrent to suicide and self-injury is a lack of access to lethal means, and I would add also supervision. And access is what determines if a feeling turns into an action. So what about social media and adolescent risk? Wouldn't it be easy if it was just all bad? But it's not all bad. It's not inherently harmful, but in adolescence, it acts as a risk amplifier. So it can intensify vulnerabilities related to mental health, suicide risk, substance use, violence, and its impact really depends on how much exposure they're having, the type of content. If they are on TikTok and the algorithm is taking them towards videos that are almost promoting self-harm or suicide, that is going to have a much different effect than being on sites where, like the Trevor Project, where they can be given information on safety hotlines and supports. The timing of the exposure to the social media, and what developmental stage they're at. One of the things that we notice is a mismatch between the content being consumed and the developmental stage that it's appropriate for exposure to that material that's being taken up. So how are some mechanisms where social media may amplify risks? So with regard to suicide and self-harm, cyberbullying and compulsive screen use have both been associated with an increased risk of suicidal ideation and attempt. Depression and sleep loss, nighttime use of devices as a significant contributing factor to sleep disruption, and that's also been associated with a significant increase in depressive symptoms, especially in individuals that were assigned female at birth. Substance use. Peers and influencers are normalizing use and also advertising use for multiple ailments for which there is no evidence base. That is leading to increased perceived acceptability in early use. I can tell you that it also can lead to a significant amount of access to substances through communication with dealers on social media. Violence and delinquency, exposure to aggressive or sexualized content can also increase the risk of aggressive or externalizing behaviors. So again, it'd be easier if it was just all bad to say, you know, we don't need this, this is inherently negative. But there are some potential protective uses of social media for youth. So whereas there are risks in bullying, depression, suicidal ideation, some youth may, again, it depends on content, find a support group or peer support or support for identity exploration that isn't welcomed in their home or community. Sleep disruption and emotional distress is an issue, but perhaps there, with increased connectedness, especially in remote areas, there is better access to mental health resources. maybe increased abilities for self-expression, early help seeking. Again, it depends on where they're seeking that help. And then there is a potential for positive community building when they are appropriately guided. So really what we're saying is that the social media's impact is really context dependent. So there are protective factors like positive peer support, emotionally uplifting content. I can't tell you how much a nice funny animal video can lift my spirits at the end of a tough day. And then active parental guidance. Risk factors are cyberbullying, toxic comparison, addictive use, poor sleep hygiene, and a lack of monitoring. And I would say that active parental guidance is more than just limiting screen time. Guidance and supervision means know what your children are looking at, know what your children are absorbing from the internet, not just how long they are staring at it. So intervention has to move beyond just putting on a screen limit to target peer dynamics, emotional regulation, family engagement, and platform design. So adolescent proofing. Privacy is something that teens really, really want more of, but they need to realize that because of their risk, by virtue of their age, it is a privilege, not a right. And when safety is in question, privacy is significantly diminished or gone. From the get-go, when a child gets a device for the first time, parents should be setting expectations that they can access that device whenever requested. If you start early before there is any identified problem, your life will be much, much easier than I will let you have free reign of your device. And when I feel as though there's a problem, I will then attempt to restrict it. If suicide risk is present or substance use, thoroughly searching their phone, room, vehicle, backpack, purse, should be undertaken when safety is felt to be compromised. Removal of the bedroom door in certain extreme situations. It's not just suicidality. I've run into children who are having drug dealers come to their bedroom window to provide them with substances. It's less likely to happen if there is an element of potentially getting caught because there is no door. Encourage parents to know what apps are on the phone and how they work, and how to set limits and track usage of the phone. And then the biggest part too is that parents need to model appropriate use of social media. If parents are behaving poorly on social media, the do as I say and not as I do approach to parenting has never been effective in the history of parenting. So firearms. Removing guns and ammunition from the home is the safest method, but realizing that if one chooses to keep a gun in the home, even with all the safety bells and whistles, the the gun's presence increases the risk of suicide. The risk is even still higher if it's in a safe behind a secret wall. If it's in the walls of the house, the risk is higher. If people are unable or unwilling to remove the gun, keeping the gun unloaded with a trigger lock in a locked cabinet with ammunition in a separate location is recommended as the best method. Encourage parents to inquire about gun ownership and storage at other homes that the children go to, and especially with like grandparents or aunts and uncles thinking about their own firearm storage. I personally ask people, where do you keep your guns? Rather than, do you have any guns? If you ask people, do you have any guns? They look at you for a second before they go, no. If you say, where do you keep your guns? It's a lot less of a stigmatizing question, and it's a little bit normalized, and you're much more likely to get an honest answer than if you just ask the yes/no question. So medications, most intentional ingestions are of a patient's own medications or a family member's prescription or the over-the-counter pills in the home. So locking up and removing all prescriptions and over-the-counter medications is ideal, and a lock box is much better than I put it at the top of the cabinet or I hide it in my room. Anybody who ever has had a child that has gone hunting for Halloween candy knows that there is nothing that a child can't find if they're looking for it. So it really is best to secure everything in a lockbox. And there are disposal boxes for unused or expired medications, both at our hospital, at most hospitals, pharmacies, police stations, and families can also order online free deactivation pouches. Teens should not have possession or control of their own medications, period. I have conversations with parents quite frequently about the fact that I understand that they're 12, 13, 14, 15, 16, and that they are going to have to take their own medications at some point in time. However, them having a bottle of their medication is not how to work that. If they are insistent that the parents are unable to give their medication every day, the child should not have the bottle of medication, but rather a days of the week pill sorter, one, so that you can see that they're taking their medication, and two, that for most medications, a week's worth of medication is not going to be a lethal dose. That is not the case for all medications, but for most medications. And making sure that parents realize that one of the most frequent causes of harm from medications is actually acetaminophen, and that there have been children significantly sick and even intubated from ibuprofen and aspirin ingestions. A lot of times people think that over-the-counter means safe, and it does not. And then again, thinking about where are the medications at other places their child may go to. Where is grandma keeping her medications? Because I guarantee you that the older population has a host of pills that can be significantly dangerous when overdosed upon. Other considerations, people just don't think of all the different ways that people can hurt themselves. But unfortunately, the kids have the internet. They're in these chat groups. They're very resourceful. So just thinking about like cords, ropes, belts, sharpened knives being secured, razors. You don't have to say you can never shave again, but you know, you're going to leave on your underclothes, shave your legs. You're going to hand me the razor back. I'm going to check you for cuts, and we're going to lock the razor back up. Cleaning supplies, especially bleach and other fluids, power tools, crossbows, swords, throwing stars. I've seen all of them. Drug paraphernalia, alcohol, big one. Lock the liquor cabinet, or consider a separate fridge for alcohol that can be locked if necessary, or just don't have alcohol easily accessible in the home where they're adolescents. And always remember, a vehicle is also a potential lethal weapon, so consider restricting access to their keys and driving privileges, not only for suicidality, but also for substance use. Some of the takeaways that I'd like you to have from our talk today are that adolescents are not broken, they're developing, and sometimes their behaviors can be very frustrating, but their actions can make more sense when we see them through a developmental lens. We need to know how environmental exposures interact with developmental trajectory to affect risk so that we can educate and intervene. We need to educate caregivers on how to mitigate risk, both by being aware of their child's activities online and in real life, and also by actively decreasing access to lethal means. Considering the large percentage of youth who pass away from suicide, who have interacted with the medical system in the days, weeks, months, and year prior to their death, we in CL Psychiatry are uniquely positioned to act, to identify and intervene in some of these youth who are at risk. Because the right intervention at the right time can change a life. And that is the end of my presentation. And here is a list of my sources.